This is a very interesting topic that I have a lot of special interest and experience with for many years already. Botulinum toxins, the first thing that I want to mention is that there are several different botulinum toxins there that are commercially available. Some folks equate this to Botox, but it's just one of the botulinum toxins that is available in the market in the United States. There are 3 botulinum toxins that are type A toxin and one that's type B that are approved by the FDA in the United States. The main mechanism of action of botulinum toxins that has been well established and proven is the inhibition of the release of acetylcholine from the presynaptic terminals. And the action that causes is that whatever the effector organ, typically in most cases muscle, is actually toned down. So in terms of the contraction of the muscle, it's actually weakened to some degree, and that could be helpful in some neurological conditions. Now, a second mechanism of action that has been proven to some degree, particularly in animal studies and in vitro studies, has been the inhibition or release of other neurotransmitters from the synaptic vesicles that go into the synaptic cleft and actually affect they actually exert their effect, specifically calcitonin gene-related peptide and glutamate. When you inhibit the release of some of these neurotransmitters that are clearly linked to the development and the maintenance of a chronic pain state or neurogenic chronic inflammation, you could potentially exert an effect that will decrease the chronic effects that we see in terms of this chronic neurogenic inflammation. The applications are actually numerous, and I'm going to be discussing some of them, including chronic migraine, myofascial pain, other types of headaches, greater occipital or occipital neuralgia, Raynaud's syndrome or Raynaud's phenomenon, low back pain, piriformis syndrome, thoracic outlet syndrome. So actually the specific indications are growing and growing, and there's more and more evidence with the, of course, the caveat understanding that most of those are non-FDA approved, so they're off-label indications, but there's actually pretty good data out there that is showing their efficacy. That's an interesting topic in the sense that a big part of the use of these agents has to do with their cost. So many times what you see published, what you see in terms of short case series and the experience that most practitioners that deal with this are dealing with on a daily basis is that they tend to use it as a kind of like a last resort because other modalities have failed. That sets you off for essentially being addressing or treating a particularly difficult cohort of patients that are kind of recalcitrant or resistant to a lot of other therapies. In fact, one of the challenges is that being an expensive therapy, if you could define what groups of patients actually have better response to or are going to, you can predict a good response to these toxins, it would make it a much more cost-effective treatment. But as it is right now, in terms of pain right now, there's the FDA has actually an approval for Botox specifically for chronic migraine, which is a specific disease entity by the International Headache Society, specific diagnosis that has specific diagnostic criteria. And also, you can see it often used for the pain associated with cervical dystonia that can be actually quite painful in the neck. For many of the other indications, there are a couple others that are particularly notorious, which specifically you can use it for post-radiation fibrosis and neck pain. You can use it for piriformis syndrome, that there's pretty solid evidence on that, and for Raynaud's phenomenon, that actually could be treatment that not only decreases pain, but can reduce the incidence of ulceration and even amputation of digits when you're talking about distal phalangeal amputations, which can be a disease-modifying effect, certainly. Chronic migraines, of course, is another one that has become the one specific pain-related indication for which there's proven evidence of effectiveness of Botox specifically. For different entities, you have to probably put it in different tiers, so to say, or different timelines of when you want to treat this. But the one thing that I want to emphasize here is that there are multiple different agents. They are they are dosed differently. They have different indications, approved and not approved indications, and that the units are certainly not interchangeable between one and the other. So you shouldn't be. It's not this. You cannot say we tried this one and then we're gonna swap to the other one. They're completely different agents, even though they're the same base compound, but it's manufactured differently. And providers should really think about this because it's actually a very safe. Contrary to what the word toxin, that is a little bit scary, it is extremely safe in experienced hands, and the side effect profile is actually very, very favorable, and they have some good results in some of the indications.